Welcome to the deep dive. Today, we're embarking on really quite a fascinating and often challenging journey into equine health. We're looking at the world of malabsorption in horses.
Hmm.
Our mission for this deep dive is basically to unravel this mysterious condition where horses, well, they struggle to absorb vital nutrients. We'll explore what it is, how it often kind of hides in plain sight, the intricate detective work involved in diagnosing it, and, the multifaceted strategies veterinarians use for treatment. It's a real puzzle, isn't it? And we're going to try and piece it together for you.
Absolutely. And to truly bring this puzzle to life, we've got a comprehensive overview looking at the scientific fundamentals, the diagnostic pathways, and crucially, a really compelling real-world case study.
Ah, okay.
Yeah, you'll follow the story of Storm, a horse who battled severe malabsorption. We can see the diagnostic journey and treatment outcomes unfold step by step. It's a perfect example, really, of how complex these cases can be.
Okay, so let's unpack this then. What exactly is malabsorption in horses? I mean, what are we actually talking about when we say a horse isn't absorbing nutrients?
Well, at its core, malabsorption, or sometimes called malassimilation, it's when the horse's intestine, whether it's due to a widespread or maybe a localized issue, it simply can't effectively transfer nutrients from the food in its gut into the bloodstream.
Okay.
Think of it as a kind of breakdown in the system that's supposed to pull out all the good stuff, carbohydrates, proteins, fats, vitamins, minerals, from their digested food.
Right, so it's not just about not eating enough food.
Exactly. It's about not using what they eat properly.
So like a nutrient thief working inside the gut. And we see two main types mentioned, right? Transient and chronic.
Exactly. Transient malabsorption is typically short-term, often linked to maybe a passing viral or bacterial infection like a bout of enteritis. It usually resolves as the infection clears up and the gut sort of recovers. Chronic malabsorption, though, that's the persistent long-term challenge. This is where we see those ongoing issues like internal parasites or what we call infiltrative bowel diseases, even rare conditions like amyloidosis or, unfortunately, certain cancers.
And it's usually the small intestine.
Yes, the small intestine is most commonly affected in chronic cases, but the large intestine can definitely be involved too. What's truly fascinating here, I think, is the underlying mechanism. If you imagine your intestine's inner lining, think of it like a plush carpet with countless tiny finger-like projections. Those are the villi.
Right, I remember this from biology.
Exactly. And these villi are absolutely vital for absorbing nutrients. So in malabsorption, you often see a loss of this absorptive area or damage to the villi themselves, a condition known as villus atrophy. It's like those carpet fibers wearing down flat, drastically reducing the surface area available for nutrient uptake.
Wow.
You can also see a thickening of the intestinal wall itself, maybe due to inflammation, swelling, or even scar tissue, which physically blocks absorption. And even blockages of the lymphatic drainage system that's called lymphangiectasia. Crucial vessels that carry fats and fluids get blocked. Or just decreased blood flow can play a role. And of course, extensive surgical removal of parts of the small intestine can lead to it too.
And for those chronic cases, our sources mention something intriguing: uncontrolled immune reactions. That sounds like the body is, I don't know, accidentally working against itself.
It absolutely can be, yeah. Often, the immune system, which is designed to protect us, right, it goes awry within the gut. It triggers inflammation that damages those critical absorptive surfaces. This is often the case with those infiltrative bowel diseases we just mentioned.
Okay, so this condition can be a bit of a chameleon then. The signs aren't always screaming malabsorption, which must make it incredibly tricky for owners and vets to spot early on.
That's exactly right. The hallmark of chronic malabsorption is often a really frustrating progressive weight loss. And sometimes this happens despite the horse having a consistently good appetite.
Yeah.
It's like a silent thief, stealing nutrients even when the horse seems to be eating normally. Other signs can be quite nonspecific. Things like lethargy, recurrent episodes of mild colic that don't seem to have a clear cause, visible muscle atrophy, and just a generally depressed demeanor.
And you mentioned sometimes you might not even see classic diarrhea, which is what I think most people associate with gut problems.
Precisely, yeah.
Yeah.
Feces can appear normal or maybe just slightly softer, especially if it's primarily the small intestine that's affected.
Why is that?
Well, the large intestine can sometimes compensate for small intestine issues, sort of masking the problem initially. However, if there's widespread involvement of the large intestine, then yes, severe diarrhea is indeed common. Other clues can include subtle changes maybe to their skin and coat, like hair loss, a rough, dry coat, skin inflammation, or even swelling, edema. Sometimes even a fever or just general weakness can be present. And this raises an important question. What's actually happening internally, metabolically?
Right.
A critical clue is often a low level of protein in the blood, particularly something called hypoalbuminemia, low albumin.
Ugh.
This is a very significant finding because it indicates not only perhaps decreased protein absorption from food, but often also protein leaking out of the damaged gut. It's a double hit, really.
Wow, okay. So if it's not simply an issue of the horse not eating enough, what actually causes this complex problem? What's at the root of the why?
Well, we see several primary culprits. Parasitic damage, for instance, from certain worms like Strongylus species or Cyathostomes, those small red worms. So that's a significant one. And in younger horses, a different type of parasite, Parascaris equorum, the roundworm, can be the cause. These worms literally damage the intestinal lining.
Okay, parasites. What else? You mentioned infiltrative diseases. That sounds quite serious.
Yes, they are. These are chronic inflammatory bowel diseases where certain types of immune cells infiltrate and damage the gut lining. We see specific types like lymphocytic plasmacytic enteritis, often shortened to LPE. It's a bit of a mouthful, but essentially it means lymphocytes and plasma cells, types of immune cells, are flooding the bowel, causing severe inflammation.
Okay.
There's also granulomatous enteritis or eosinophilic granulomatous enteritis. Different cells, similar problem.
And do we know what triggers these?
That's the tricky part. The exact triggers for these uncontrolled immune responses are largely unknown. Allergens, maybe. Infectious agents. They're suspected stimuli. Also, chronic infections with specific bacteria like Mycobacterium avium or certain fungi can sometimes cause similar inflammatory signs.
Okay. Any other causes?
Yes. Another one that's being identified more often, particularly in young horses, is something called proliferative enteropathy. This is due to a bacterial infection, Lawsonia intracellularis. It's a unique infection that causes the intestinal lining cells to rapidly multiply, leading to thickening and impaired function.
Huh.
And unfortunately, we also have to consider alimentary neoplasia, which is cancer of the digestive tract. Things like lymphosarcoma can also disrupt the gut's ability to absorb nutrients.
Right. Given all those varied and, as you said, often subtle signs, diagnosing malabsorption sounds like some serious detective work for a vet. How do they even begin to piece together the clues?
It truly is. It's a full-on investigation, you could say. It always starts with a really detailed history from the owner and a thorough physical examination. First, you want to rule out the more common causes of weight loss, things like, is the horse getting enough good quality feed? Are there significant dental problems? Is there competition for food in a herd situation?
Standard checks first.
Exactly. Get the basics covered. From there, it becomes a much more systematic approach, often following a trail of, well, breadcrumbs.
So once they suspect malabsorption, is blood work one of the first sort of real clues they look for? What does that tell them?
Blood tests are absolutely crucial, usually in the initial stages. Common findings might include anemia, so low red blood cells, or changes in white blood cells like neutrophilia, which can indicate inflammation. But the most significant finding, often a real red flag, is that hypoalbuminemia we talked about, those dangerously low levels of albumin, a key protein.
Right, the low protein.
Yes. In Storm's case, as we'll discuss, his albumin was strikingly low. You might also see a mild elevation in fibrinogen, another indicator of systemic inflammation, and sometimes changes in certain liver enzymes too. These findings help confirm that something serious is happening internally, pointing towards the gut.
Okay, this is where it gets really interesting for me, and I think for the listener too. How do vets directly test if the horse is actually absorbing nutrients? It's one thing to see the signs, but how do they prove the gut isn't doing its job?
Right. That's where the carbohydrate absorption tests come in. Specifically the D-xylase, or more commonly now, the glucose absorption test, sometimes called the oral glucose tolerance test, or OGTT.
How does that work?
Well, after about a 12-hour fast, a measured sugar solution, glucose in this case, is given to the horse, usually via a nasogastric tube. Then, blood samples are collected at timed intervals, typically over a couple of hours, to see how much of that sugar actually makes it into the bloodstream.
And what are they looking for?
They're looking for a rise in blood glucose. If the horse has what we call a blunted curve, meaning a low or no significant increase in blood sugar compared to its baseline, it's a strong indicator of an absorption defect in the small intestine.
What's considered normal?
For glucose, a healthy horse would typically show about a twofold or maybe 100% increase, sometimes even more, over its baseline blood sugar levels within about 90 to 120 minutes. If you don't see that kind of rise, it tells you pretty clearly the absorption isn't happening as it should.
So that's the direct evidence. What other tools are in the veterinary detective's arsenal once they've got those initial clues from blood work and the absorption test?
Abdominal ultrasonography is another key tool.
Hmm.
It allows the vet to visualize the small intestinal wall, actually measure its thickness, and look for any masses or other abnormalities.
So they can see physical changes.
Yes, exactly. Thickening is a common finding. Then we often move towards biopsies. A rectal mucosal biopsy is less invasive. You can take a small pinch from the rectum. It can sometimes reveal diffuse inflammatory disease if the lesions happen to extend all the way down to the rectum. But a negative result isn't definitive. The problem might be higher up in the gut.
Right, so it might miss the spot.
Precisely. So for a definitive diagnosis, especially when you suspect those infiltrative bowel diseases like LPE, small intestinal biopsies are often required.
And that sounds more involved.
It is. It's a significant step. It involves general anesthesia and a ciliotomy, basically, a surgical incision into the abdomen to obtain full-thickness samples directly from the affected intestine.
Are there risks with that?
Yes, there are risks, especially because horses with severe malabsorption can be in a catabolic state. Their body is breaking down its own tissues due to that nutrient deprivation, which can complicate anesthesia and healing. But it's often the only way to truly confirm the specific underlying cause and get a definitive diagnosis.
Okay, to make this really concrete, let's talk about Storm, the 10-year-old quarter horse gelding from our sources.
Yeah.
What was his story, and how did his diagnostic journey actually unfold?
Right. Storm's story is a really good illustration. It's quite a classic presentation of chronic malabsorption. He came into the clinic with about a 6-month history of progressive weight loss. And this was despite him having a consistently good appetite, which is key. He also had decreased energy and occasional episodes of mild colic.
And his manure.
His feces were described as normal to slightly soft. And his body condition score was quite low, a 3 out of 9. So visibly underweight and losing muscle.
So all those subtle, sort of chameleon-like signs you mentioned were certainly present in his case. How did the vets begin their investigation with Storm?
Well, the initial blood work was absolutely key in Storm's workup, as it often is. His complete blood count showed mild anemia. But the most significant finding, really the glaring red flag, was his severe hypoalbuminemia.
How low was it?
It was just $1.09% GDL low.
Oh.
Which is dangerously low.
This strongly suggested a protein-losing enteropathy, meaning his gut was not only failing to absorb protein, but was actively losing it into the bowel.
Wow.
His fibrinogen was also elevated at $500 mgdl low, indicating significant systemic inflammation was going on.
And the absorption test for Storm, the glucose test, did that confirm their suspicions?
Yes, the glucose tolerance test was very telling. It really helped crack the case. Storm showed a severely blunted glucose curve. His peak increase was only 10% over his baseline glucose level. Remember, we expect a healthy horse to show maybe a 100% increase, or at least 50% in many protocols.
So way below normal.
Way below. This dramatically confirmed a severe defect in his small intestinal carbohydrate absorption. It was clear his gut just wasn't pulling its weight, so to speak.
What other clues did they find through imaging or those less invasive biopsies?
The abdominal ultrasonography revealed diffuse thickening of his small intestinal wall. They measured it up to $5, which is definitely thickened.
Okay.
So that physical change immediately confirmed an issue within the intestine itself. A rectal biopsy was also performed, and it showed lymphocytic plasmacytic infiltration. That was suggestive of inflammatory bowel disease, but it wasn't yet definitive for his specific issue or its severity.
So with all those clues really pointing in a specific direction, the weight loss, the appetite, the low protein, the failed absorption test, the thickened gut wall, what was the definitive diagnosis for Storm? What did they have to do to finally solve the mystery?
Right. Given his persistent weight loss, that severe hypoalbuminemia, and the clearly abnormal glucose absorption test, the decision was made to proceed with an exploratory laparotomy. And during that surgery, they took full-thickness small intestinal biopsies. This was the critical step.
And the results?
The histopathology, looking at the tissue under the microscope, confirms severe lymphocytic plasmacytic enteritis, or LPE. The biopsy showed intense infiltration of those inflammatory cells, the lymphocytes and plasma cells, alongside significant villus, blunting those flattened villi we talked about, and something called crypt hyperplasia, which means the base of the villi were abnormally growing.
So that was it?
That was it. This inflammation and damage was the clear underlying cause of Storm's profound malabsorption.
Okay, so once they had finally cracked the case with Storm's diagnosis, what was the thinking behind his treatment plan? How did they approach helping him recover from such a severe condition?
Well, For Storm's severe LPE, the cornerstone of treatment was corticosteroids, specifically oral prednisolone.
To reduce inflammation.
Exactly. This powerful medication was given to suppress that overactive immune response in his gut and reduce the inflammation that was destroying those crucial villi. It was started at a relatively high dose and then gradually tapered down over about 8 weeks.
And what about feeding him? That must have been critical.
Nutritional support was absolutely paramount. He was transitioned to a high-fat, highly digestible commercial senior feed. They also added vegetable oil to significantly increase his caloric density.
Okay.
And feeding frequency was key. Frequent, small meals, 4 to 5 times daily, was crucial to try and maximize whatever digestion and absorption he could manage.
Made sense.
Yeah. They also supplemented him with probiotics to support his gut flora, vitamin E, which is an antioxidant, and a balanced vitamin-mineral mix to cover any deficiencies. And there were some adjunctive therapies too. Metronidazole, an antibiotic, was used in case there was any secondary bacterial overgrowth in his damaged gut. And omeprazole, the ulcer medication, was given to help prevent gastric ulcers, which can be a risk with corticosteroid use.
Right. A comprehensive plan. And what was the outcome for Storm? Did this multifaceted approach actually work?
Storm's response was truly remarkable, actually.
Yeah.
Within just a few weeks, his owners reported his energy improved dramatically, and he steadily began to gain weight.
It's fantastic news.
It really was. Within 6 months, he had reached a body condition score of 5 out of 9, which was a significant improvement from his initial score of 3. And his colic episodes also ceased completely.
So, a success story.
Very much so. While the prognosis for severe LPE like his can often be guarded to poor, Storm's case vividly demonstrates that an aggressive diagnosis and a really tailored multimodal treatment plan can lead to a very favorable outcome and a good quality of life. It's a testament, really, to dedicated veterinary care and diagnostics.
Yeah, definitely. So based on Storm's impressive recovery and the general overview you've given, what are the sort of key principles for treating equine malabsorption more broadly? What should owners and vets be thinking about?
Well, treatment always varies based on the specific underlying cause. That's the first thing. For transient diseases, it's primarily symptomatic care supporting the horse as its body recovers. For the chronic conditions, though, diet is absolutely critical. Feeding highly digestible, often high-protein feeds, ensuring high-quality fiber for the large intestine. And typically, feeding him multiple small meals throughout the day is best.
Right.
Surgical intestinal resection is technically an option, but really only for very localized disease, which is unfortunately quite rare in these types of infiltrative or widespread cases.
Okay. What about medications?
Medically, well, for parasitic causes, you need effective anthelmintics dewormers, like ivermectin or moxidectin. Though we do have growing concerns about drug resistance, which can complicate treatment significantly.
Yeah.
For those infiltrative bowel diseases, as we saw with Storm, corticosteroids like prednisolone or maybe dexamethasone are indeed the drugs of choice. But these are powerful medications, and they require careful monitoring due to potential side effects, like the risk of laminitis, which is always a concern in horses.
Definitely.
Antibiotics, such as trimethoprim sulfonamide or metronidazole, might also be used either for specific bacterial infections if identified, or sometimes to manage suspected bacterial overgrowth in a dysfunctional gut.
And what about the long-term outlook for a horse diagnosed with malabsorption? I mean, is there hope for a full recovery for all of them, or does it really vary?
It varies significantly, and it depends entirely on that underlying cause. For parasitic infections, the outlook can range from poor to good, depending on how severe the damage is and how well the horse responds to treatment. Unfortunately, for severe infiltrative bowel disease like LPE, and certainly for cancers like neoplasia, the prognosis is often considered guarded to poor. It can be very challenging.
But Storm did well.
Exactly. As Storm's case clearly shows, aggressive diagnosis coupled with a comprehensive, tailored treatment plan and really diligent long-term monitoring, watching their appetite, demeanor, feces, body condition that can dramatically improve the outcome, even in severe cases like LPE. It really shows that even when the odds seem stacked against them, there can be a pathway to a very good quality of life.
This deep dive into equine malabsorption has truly shown us the incredible complexity, hasn't it? Diagnosing and treating conditions that affect something so fundamental as nutrient absorption, from those subtle, almost invisible signs to the cutting-edge diagnostics that require such specific, almost detective work, it's a truly fascinating field.
Indeed, it really is. We've seen how a thorough workup, involving everything from those initial blood tests and the absorption challenges through to detailed imaging like ultrasound and ultimately sometimes needing surgical biopsies. how all that is often necessary to really pinpoint the exact cause and then craft an effective treatment plan. That multimodal approach, combining meticulous dietary management with powerful medications like corticosteroids, is often key to unlocking a positive outcome.
And it really makes you think about how incredibly intricate the body's systems are, even in our horses. Just astonishingly complex.
Absolutely. And while we've made huge strides in identifying and treating these complex conditions, it's still quite striking that for many chronic inflammatory bowel diseases, like that lymphocytic plasmacytic enteritis, fundamental triggers, the initiating factors, often remain unknown. We treat the inflammation, but we don't always know precisely what started it. It makes you wonder, doesn't it? What is this persistent challenge in understanding the absolute root causes of such complex diseases tell us about the ongoing frontiers of medical and veterinary science? How much more is there yet to discover about how bodies, both equine and human, really truly function, malfunction, and ultimately how they heal?